Manager at the Louisiana Office of Public Health, STD HIV Hepatitis Program. And I just want to welcome you all to the Louisiana Monkeypox Update. We have a very full agenda for this 1 hour meeting. So I'm right away going to hand it over to the SHIP Director, Sam Burgess. Sam, are you ready?
Ready. Thank you, Julie, and good afternoon, everyone. Just saying welcome and thank you for your participation. We are going to cover the current state of the monkeypox outbreak in Louisiana, what that looks like, and also what our response efforts are to date. Also talk about the limited availability of vaccines and treatment medications, and then open up the call for questions and answers. But we'll start with an overview of where we are with monkeypox from our state epidemiologist, Teresa Sokol, also the director of our Office of Public Health's Infectious Disease Epidemiology Program. Teresa.
Okay, thanks, Sam. Can y'all hear me? Yeah, okay, great.
Yes. Here you go.
Thank you. I'm going to share my screen. I'll take just 1 second. Okay. So as Sam said, I'm the state epidemiologist in Louisiana. Hope everybody's having a wonderful afternoon. And before I start, I really just want to thank everyone here for partnering with us, because I know that everybody on this call is committed to participating in the important efforts to mitigate what is unfortunately a growing monkeypox outbreak, both globally within the US and in our own state. I do want to just also introduce Jenna Iberg Johnson. She's Deputy Director of Infectious Disease Epi, and she will be on, she's on the call as well, and she's going to be helping to field questions and respond in the chat when possible. So just wanted to flag that for you all. So first I'm going to start with just a brief background about monkeypox, which a lot of you may be familiar with by now. So monkeypox belongs to the orthopox virus family, and that includes also cowpox and smallpox, which monkeypox is closely related to. It was first detected in some research monkey colonies back in the late 1950s, but the first human case was not detected until 1970, and that occurred in the Democratic Republic of the Congo. Since that time, the first human case, monkeypox has been detected and reported in several countries in Central and Western Africa. It's thought to be endemic. It's considered to be endemic in those areas only. Now, we have had in the US previous monkeypox cases that occurred in people outside of those endemic countries, but these cases were always linked to international travel to an endemic area or to contact with imported animals that had come from one of those endemic areas. Recently, the picture has changed. It's starting in early May of this year. Cases of monkeypox began to be detected first in some countries in Europe, specifically England, Spain, Portugal, and many of these were not related to international travel. And so it was quickly understood that there was circulation happening within these previously non-endemic countries. So since that time, with the early detection of cases, cases have been identified in many countries. CDC and the World Health Organization are tracking this outbreak across the globe. And what has been identified so far among information collected from the cases that we've identified and been able to conduct investigations with is that the highest number right now of cases have been detected among gay, bisexual, and other men who have sex with men. Not all of the cases are among members of that community. And keep in mind that anyone can get infected with monkeypox. It's an important message that we're trying to really promote from the Office of Public Health, certainly. I do want to talk a little bit about monkeypox symptoms, and specifically because what we're seeing now in this current outbreak, the presentations can be slightly different than what are the classic presentations that are seen in these endemic countries. And the reason that this is so important to keep in mind is because testing, I think, needs to be happening a little bit more broadly than it is. And I think it's perhaps because people are expecting monkeypox to present the way they've known it to present from the endemic countries, sort of that classic presentation. So in the current outbreak, we have, sort of a standard set of symptoms that the monkeypox infections can include. They don't include all of these: fever, headache, muscle aches, joint pain, lymphadenopathy in one or more areas, chills, exhaustion, just really not feeling good. And then, of course, there's a rash. All of the cases that we've identified so far have had a rash. It can look like pimples or blisters that appear on the face and the hands, the mouth, and other parts of the body. And that includes, which is unusual for rash illnesses, also can appear on the palms of the hands and the soles of the feet, as well as what we're seeing a lot of in this current outbreak, the occurrence of lesions in the anogenital area. Now, historically, the characteristic rash was preceded by prodromal symptoms, some of the ones that I've just described. And this is specifically, we would most often see fever and lymphadenopathy and other types of flu-like symptoms. People just wouldn't feel good. And then the lesions would occur usually 1 to 2 days after the onset of the prodrome. The typical monkeypox lesions are well circumscribed, they are deep-seated, and they often are umbilicated. So they have a little depression or what appears to be a dot in the center of the lesion. In the current outbreak, prodromal symptoms are often very mild or they're not occurring. And often lymphadenopathy and fever are not present. Some people are getting the rash first, and then other symptoms appear later. The rash that we're seeing, it can be scattered or diffuse. Sometimes it's limited to just one body site. It can be, sometimes we'll see just in the mucosal area, in the mouth, around the lips and face, or in the anogenital region, as I've mentioned. The rash typically goes through different stages before healing. And in the current outbreak, unlike the cases that occur in endemic countries, the lesions that can occur and be seen in different phases, even side by side to one another. Unfortunately, the illness typically lasts 2 to 4 weeks, which is quite, can create quite a burden for a lot of the patients. If you talk about transmission, this is, of course, very important to everybody. Most of the spread that we're seeing, most of the transmission in the current outbreak has resulted from close, intimate contact with an infected individual. It's most often spread through direct contact with the sores or rash of someone who has the virus. Now, fomite transmission is also possible and presents a high risk for exposure. And that's contact with clothing, bedding, and other items that have been used by a person who has monkeypox. It can also be spread through respiratory droplet transmission, but we're talking about large respiratory droplet transmission. So it really needs to, in order for the disease to be transmitted in this way, there needs to be close, prolonged face-to-face contact. And this often would occur during intimate physical contact, such as kissing or cuddling. The good thing about this virus, which is different, as we all know from COVID, for example, is that people who don't have symptoms cannot spread the virus to others. So as I talk a little bit about the public health response, when I'm talking about symptom monitoring, that's why it's so important, because people need to be vigilant if they've been exposed for identifying development of symptoms, because that's when they can begin to spread the disease to others. A person is infectious with monkeypox. An infected person is infectious from the time the symptoms start until the rash has fully healed. And that means all the lesions have scabbed, they crusted over, the scabs have fallen off, and a fresh layer of skin has formed underneath. And that can take quite a long time. Now, of course, it's also possible for people to get monkeypox from animals if they're bitten or scratched by an infected animal, or they prepared or eaten meat from an infected animal, but that's really not how the current outbreak is occurring. This is just to give everybody a quick snapshot of what our case count is, what the disease burden is that we've been able to identify, I should say. And this is as of yesterday. So across the globe, we have identified almost 16,000 cases across 66 countries that were previously not endemic for monkeypox. In the US, almost 2,600 cases, and you can see from the map there that almost every state has identified at least one case. In Louisiana, we have, as of today, what we reported today, identified 21 cases. 20 of those are in LDH Region 1, which is Southeast Louisiana, and one is in Region 9, which is the North Shore. I do want to just flag our Monkeypox Dashboard. So it's now live. It includes statewide case counts, and it now, even though this is a little bit of an old screenshot that I took, but it will soon include, if it doesn't already, I think it's going to soon include breakdown by LDH region. And it includes some resources such as FAQs and HANs, and we're going to be adding different resources that are geared toward the questions and concerns that different audiences may have. So we'll have information for providers, we'll have information for patients, for those who may have been exposed, that sort of thing. So look for that in the future. Oh, I do want to highlight that as I think pretty much everybody on this call knows, vaccine is currently being distributed to a limited number of provider locations for administration to patients who are at greatest risk to have had a recent exposure. Additional vaccine sites are going to be added as supply increases. Right now, and I'll show you later exactly how many doses we have. We have an extremely limited supply. We will be posting the locations where vaccine is being distributed on a web page within the Monkeypox Dashboard, so that members of the public can understand if they're eligible for the vaccine and where they might be able to seek one out. But we are going to emphasize that these are limited doses that are being distributed at this time, and we're going to update the site so that we can remove or flag the sites that have already exhausted their supply. So I want to talk about the Monkeypox Public Health Response. What are we doing to try to prevent additional cases from occurring, to try to curb transmission of monkeypox? It all starts with early case detection at this point until vaccine becomes much more widely available. Early case detection is of the utmost importance because it helps guide clinical decision-making, which can improve patient outcomes. It can, containment measures can be implemented quickly upon early case detection. And then what some people may not know is that early case detection and really being able to identify all the cases that are actually occurring is important for vaccine allocation, because CDC looks at the number of cases that are occurring in a jurisdiction to help determine what their need for vaccine is. So if we have a lot of transmission that's occurring, but those cases are not being detected, then CDC thinks that we perhaps don't have as widespread a problem as we might. So we'll get less vaccine as a result. So we really need to make sure, for a lot of different reasons, that we're trying to catch these cases early. We're doing some good testing. In terms of containment, I think people are familiar with a lot of what we're doing. We are conducting contact tracing for monkeypox. So we will reach out to an infected individual. We will ask some questions about where they might have been exposed and about others that they might have exposed during their period of infectiousness. We also reach out to those contacts, and we work to try to determine what the level of risk is, what the level of exposure is. So for example, someone who is a household contact or a sexual contact, that person is going to have a high level of exposure. And those are going to be the individuals that are really going to be targeted for post-exposure prophylaxis. Someone who had a very brief interaction, even if they were unmasked, we're talking about 15 or 20 minutes, even an hour, that's going to really be considered low risk, for example. And for the individuals that are usually at intermediate or low risk and do not need post-exposure prophylaxis. We do still engage in symptom monitoring with them because, as I said, we know that as soon as someone develops symptoms, they could be infectious. So we want to be able to work with individuals to identify when they develop symptoms quickly and try to get them in for testing as quickly as possible. What we're using for symptom monitoring, just so folks know and can communicate as needed, is a system called TIMS. It's a CDC system. It's a text illness management system. And it actually, one thing I like about it is that it's very low burden in terms of time and effort required for a patient. Used to be years ago, epidemiologists would call a patient every day or an exposed individual every day when they needed to be monitored for symptoms. Now they get an automated text message, they just quickly answer, and it's a very easy process for everyone. They can always call our 24/7 hotline if they want to report symptoms, or if they report it into the system, we get an alert and then we can reach out and contact that patient. We do have resources available for individuals who are awaiting test results, and also individuals who are exposed. And so we will be distributing those. Those will be posted on the dashboard, and we can also distribute those after the call as well. I think there's going to be a provider packet that goes around. As I mentioned, post-exposure prophylaxis of the vaccine with the vaccine is for high-risk contacts. I'll talk about that a little later. And then there's also a treatment available, an antiviral medication for those who have either more severe illness or who have conditions that place them at high risk for severe illness. So I do want to spend a little bit of time on monkeypox testing because I do think that there's a need for increased testing in Louisiana. As I said, I think that there are undetected cases that are occurring, and I think part of the issue that's happening is that some of these patients are presenting with very atypical symptoms, and so providers aren't automatically thinking monkeypox. So here's when CDC and LDH want folks to be tested for monkeypox. We want folks to obtain swabs, and these are lesion swabs. On anyone if there is a classic monkeypox presentation, or if there's a presentation with a rash that could possibly be consistent with monkeypox, and you just don't know, but that person also reports contact with a person or people with a similar appearing rash, or we've had a diagnosis of monkeypox, or they've had close or intimate in-person contact with someone in a social network experiencing monkeypox activity. And I think it's important to note, I've heard a lot of providers, they might identify an STI and think, okay, that explains it. I don't need to test for monkeypox. However, an STI diagnosis does not rule out the presence of monkeypox. Co-infections can occur, and they have occurred at this outbreak. So we encourage you, even if there's an STI diagnosis among folks who meet those criteria for testing that I mentioned, I would encourage you to go ahead and test those individuals for monkeypox as well. So testing is available through the state public health laboratory, but also now through 5 reference laboratories: LabCorp, Mayo, Quest, Aegis Sciences, and Sonic. And I just want to highlight some differences between these labs. So the state lab right now has a 1-day turnaround time. They test Monday through Friday. So that's a pretty good turnaround time. We also provide transport. And so generally the samples can get to us more quickly. So generally there's a quicker turnaround time, and there is no cost associated with either the transport or the testing itself. But I will say this: reference laboratories, their processes are often better known, more familiar to providers, and they have a more streamlined process. There are additional requirements in terms of labeling and data submission when tests are going to be performed at the state public health lab. So I just want to flag for everybody, there are those 2 options. And if you have questions, if you want, anybody can use the state lab. If you want to use LabCorp or Quest or Mayo for the majority of your samples, but you, for example, have an undocumented worker who for whom it's going to be better to have a no-cost test, you're certainly welcome to send those samples to the state lab. I've listed the link here to CDC specimen collection page that provides more details about the best way to collect samples. I will say this, we're getting a lot of questions about whether or not other locations can be swabbed, and there can be tests for monkeypox performed, for example, from oral swabs or throat swabs. CDC is researching this, but there has been no guidance, and that testing is not available at this time. I want to talk about vaccines. There are so many questions, and I think there's also a lot of confusion between these two vaccines. There are two vaccines that are FDA licensed, and they are available for preventing monkeypox infection. This is Jynneos and ACAM 2000. Jynneos is a live attenuated vaccine. It is non-replicating. ACAM 2000 is a live, but it's replicating. It's a replication competent vaccine. So Jynneos is administered as a subcutaneous injection, like any other vaccines that you see. But ACAM 2000 is administered with multiple pricks of a bifurcated needle. And so a lesion develops at the site of the injection. There's replicating virus at this site, and it can result in inadvertent inoculation and self-inoculation. And it also carries an increased risk for severe events associated with uncontrolled replication. And so that's why it's contraindicated for some people, such as those with a weakened immune system, people with certain skin conditions, or pregnant people. One of the problems is that there's a whole lot of ACAM 2000s available, and a very limited supply of Jynneos. In Louisiana, really, and all other jurisdictions that I've heard of, the choice has been made to rely on Jynneos because of all of the factors that I've just mentioned. But unfortunately, it's going to take a little bit of time for us to get an abundant supply in hand. People are considered fully vaccinated about 2 weeks after their second shot. There are 2 doses in this series. They're administered 28 days apart. And I think we'll go on to the next slide. Okay, let's talk about uses of the vaccine. So there are 3 strategies that are currently being used in the US. One is post-exposure prophylaxis. That's when, or it might be called standard PEP. That is when people are vaccinated following a known, and in this case, high-risk exposure to monkeypox. And if it's administered within 0 to 4 days after exposure, it can help prevent illness entirely. It can be administered all the way up to 14 days after exposure, but if it's administered after between 4 and 14 days, then it probably is not going to prevent disease, but it can help reduce the severity of the symptoms. So we are providing post-exposure prophylaxis to high-risk exposed individuals through day 14 after their exposure. So expanded post-exposure prophylaxis, or PEP++, is when people with certain risk factors that make them more likely to have been recently exposed to monkeypox get vaccinated. So essentially, we're vaccinating people that we think have had an exposure, but we just don't know about it. And so we consider them to be at high risk for infection as well. Pre-exposure prophylaxis really refers to administering vaccine to someone at high risk, in this case for monkeypox. And really, it's very limited at this point, and specifically usually only for laboratory workers who handle specimens that might contain monkeypox. Here are the Louisiana allocation numbers. So we originally requested 60 doses when we first started seeing our first couple of cases, and that was really just for post-exposure prophylaxis. Then the federal government developed this national strategy where they were going to allocate in different phases certain numbers of vaccine doses. Phase 1, the determination of which jurisdiction got how many doses was made entirely on case burden. So at that time, we didn't have any cases detected, and we got 0 doses. Phase 2A allocation was weighted equally between case burden and also an estimate of population, the MSM population, and the number of folks with HIV diagnoses in a jurisdiction. So for that allocation, we got 1,049 doses. Phase 2B had those same two factors that were considered. However, the case burden accounted for 75% of the weighting in that situation. We got 973 doses for that allocation. Phase 3 distribution is expected, hopefully in a couple of weeks, and it's expected that 800,000 doses will be distributed nationwide, but the Louisiana allocation isn't known at this time. So for PEP++, each jurisdiction has to determine eligible groups for the vaccine. We certainly want anyone who is at risk to be able to get the vaccine, but at this time, unfortunately, because of the amount we have to prioritize. So the eligibility criteria that we are using in Louisiana are the individual has to be gay, bisexual, or other man who has sex with men, and within the last 14 days has either had intimate or sexual contact with multiple or anonymous partners, or has given or received money or other goods in exchange for sex, or has had intimate or sexual contact with other men in a social or sexual venue. These eligibility criteria were chosen based on best practices learned from other states that started seeing cases before we did, and also the limited Louisiana experience that we have at this time. Now, I want to assure everybody that we want to be as inclusive as possible while targeting those at the very highest risk based on currently available information. Please know that eligibility groups will expand as soon as we're able to do so with additional doses of vaccine. We've gotten a lot of questions about monkeypox vaccine and healthcare personnel, so I do want to touch on that a little bit. At this time, most clinicians in the US and any laboratories that aren't performing testing on monkeypox specimens are not advised to receive the monkeypox vaccine. And one of the questions and one of the points of confusion I think that there's been is among folks who might be vaccinating, I think they're thinking of a replication competent vaccine, which is what has always previously been used, and where it made sense for someone who's going to be administering the vaccine to have been vaccinated. And that's not the case with Jynneos, which is what is being administered here. It's non-replicating. There is no risk for people who are administering the vaccine. One of the reasons that's not recommended across the board for healthcare personnel who might be seeing monkeypox patients is because PPE are widely available, and we know what PPE need to be used in order to prevent exposure. So healthcare exposures can be prevented. Any healthcare provider who is going to be attending a patient with suspected monkeypox should wear gown, gloves, eye protection, and also an N95 mask. So there is an antiviral treatment that has been approved by the FDA for treatment of smallpox in adults. And it's under EA, it's under Expanded Access Investigational New Drug Protocol for treatment of adults and pediatric populations during a monkeypox outbreak. The treatment is called Tecovirimat, or it's often referred to as TPOX. Now, the prognosis for monkeypox really depends on multiple factors, and this includes whether or not somebody's been vaccinated, what their overall health status is, do they have any comorbidities, that sort of thing. Many people with monkeypox do have a mild self-limiting infection, but there are people who are experiencing severe symptoms and severe illness. And there are also individuals who are at high risk for disease, such as those with immunocompromise, pediatric populations, particularly younger kids under the age of 8, people with a history of certain skin conditions, pregnant or breastfeeding women, and then people who have some kind of complication, such as a secondary bacterial skin infection. In addition, people with lesions that are present in certain anatomical areas, these that might pose a particular hazard, such as ocular involvement or anogenital lesions. Those can be very painful. This might be indications for use of Tecovirimat as well. Now, I really want to impress this upon everybody. Tecovirimat cannot be obtained from a commercial pharmacy, and the patient cannot request Tecovirimat through the Department of Health. How it works is that a clinician needs to, I think I might have this on the next slide actually, consult either with the Department of Health or with CDC prior to release of Tecovirimat. We do have courses pre-positioned here now. So for those courses, the consultation is only with the Louisiana Department of Health, and our state pharmacist can release it upon our approval. This process happens very, very quickly because we have an 800 number for clinicians that is answered 24 hours a day, 7 days a week by an epidemiologist. Jenna, if you wouldn't mind putting that into the chat, I don't think I have it on the slide set. And so we can get the ball rolling right away, and the release can happen very, very quickly. One of the issues, though, is that because it's under IND, there are certain requirements for submission of data and completed forms to CDC and regulatory affairs. So unfortunately, this is a little bit burdensome, but CDC recognizes that and does not want those requirements to be a deterrent to providing Tecovirimat to patients who need it. And so they're trying to streamline the process. They have already removed some of the required submission elements, such as photos of lesions and submission of lesion swabs for resistance testing that they previously had in place. We've had, my number is not on here, but we've had 5 patients in Louisiana treated with TPOX so far. And I mentioned we have, well, just under 20 doses currently pre-positioned, and we'll request additional as necessary to make sure we always have some on hand. The last thing I want to focus on a little bit is confidentiality. And this is really to provide assurance to our partners. Confidentiality, of course, patient identifiers and patient information are protected across all of the Louisiana Department of Health. But the confidentiality of epidemiology investigations is actually mandated in the sanitary code. And this is unlike other jurisdictions. So this also includes and can encompass information about contact information or locations of exposure, with the exception of the need to notify the public in order to protect their health. And so really, there's a very, very broad net, if you will, that protects the confidentiality of any information that we gather pursuant to an investigation. We do realize that vaccine administration data related to this particular event are particularly sensitive because of the vaccine eligibility criteria. So the Office of Public Health is truly committed to protecting patient privacy. Not only is it the ethical thing to do, not only is it legally mandated, but we don't want patients or contacts, people who've been exposed, to have concerns and be hesitant to reach out to seek care or to seek out post-exposure prophylaxis because they have concerns whether or not their information will remain confidential. So I just want to assure everybody that we are absolutely committed to that. This is just a reference slide in case folks have not previously been aware of this. I think there's a really good COCA, which is Clinical Outreach and Communication webinar. And it's their most recent updates about clinical diagnosis and treatment. It occurred on June 29th, but a recording of the webinar and the slide sets are available. I've included the link there. But I think it provides a lot of good information about clinical presentation, about treatment options, and about the prophylaxis and the vaccine. So I think that's all I had. And I know that these slides are going to be distributed, so some of these links that I've included here will be available to everybody. So thank you very much. And I'll sort of defer to Sam, but I think we might go to the next presenter and then answer questions at the end. But Sam, I'll defer to you on that.
Yeah, let's keep moving, because I think that the material covered by the immunizations program will probably answer a lot of questions. So we'll move right on over to Dr. Shaquetta Johnson, the director of the Office of Public Health Immunization Program, and her team. Thank you, Dr. Johnson, for being here.
Okay, thank you, Sam, and thank you, Teresa. I know we're moving quickly here, so I want to be mindful of time. And just to let everyone know, the Office of Public Health Immunization Program has been charged with oversight of the transport and distribution component of the monkeypox response, as well as inventory management and tracking. So today we have Javon Davis-Charles, our operations manager, who's going to review the transportation and distribution piece.
Good afternoon, everyone. So I will go ahead and get started, like Dr. Johnson said, to be mindful of time. Okay, here we go. Okay, so like Dr. Johnson said, we're going to talk about our distribution plan. So regional allocation, it actually started this week. Regional allocation for JYNNEOS, it was determined by a work group of OPH clinical and infectious disease leadership. So what was considered when thinking about distribution was population size of individuals at increased risk that may seek PEP or PEP++ services. Future allocations may vary. It will more than likely depend on case counts, demand, and vaccine availability. So step one of our distribution plan was to get all doses that we had, which was about 1,049 doses, to all of our parish health units. So all doses have been picked up as of July 21st, 2022. Those doses are now either in regional offices or at the parish health unit. So our step two plan is partner provider distribution. So we came up with a list of medical providers to provide PEP++ administration. Those providers were identified based on having a high volume of at-risk patients. The vaccines were distributed and continue to be distributed by our immunization program regional consultants. And vaccine must be managed in our link system, which is our state registry, so we can make sure we are appropriately tracking doses. And I just want to add in, for those who may have been contacted or who we may be in talks with, thank you for people who have already agreed, and I hope that more people will hopefully consider to help us out with this. So I'll just talk quickly about storage and handling, since I understand that this is a mixed call with some community members and some medical providers. But for those providers who do handle vaccine, the vaccine has come in refrigerated. So refrigerated vaccine, it can be held at temperatures for up to 8 weeks. So you will get your expiration date once you receive your vaccine. For future allocations, it may be a possibility that those come in frozen. Those must be kept in ultra low temperature, -25 to -15 degrees Celsius, and you can see the Fahrenheit conversion. The expiration date for the frozen vaccine is August 31st of 2023. So we usually say if you get it frozen, if you're unable to safeguard it at that temperature, to please refrigerate it between 2 and 8 degrees Celsius. The vaccine must be held in an appropriate freezer or refrigeration type unit, so no dormitory or bar type refrigerators or freezers. We must use digital data logger thermometers, which is the CDC gold standard because of its ability to continuously monitor temperatures. Those DDLs must have a current and valid certificate of calibration. And we also ask to please not use after the expiration date or beyond use date. The beyond use date will probably be on the packaging, but if it's refrigerated, remember it's the 8-week time frame from the time that the vaccine had been thawed. Administration of the vaccine, each vial contains 1 dose, so it's a single dose vaccine. It's administered 4 weeks apart. It's 4 weeks apart. It's a 2-dose vaccination series, like Teresa mentioned. Once thawed, it's a milky light yellow to pale white color. Providers should visually inspect all product before administration, which, no matter the vaccine, is always a good practice. And JYNNEOS is approved for adults age 18 and older. So I will not discuss our links inventory management system on this particular call, but if there are any questions about vaccine administration, vaccine access, or links and how to properly document vaccine, please call me, please email me. Here's my contact information. Thank you.
Okay, and we've had a couple of questions, and Jenna, thank you so much. You've been doing a great job of responding in the chat, but just want to make sure that we've addressed everyone's questions and see if there are additional questions that people want to unmute to ask, verbally, or feel free to type in the chat box. But I think there were a few about sort of vaccine efficacy, or how long it takes for the vaccine to be effective, and how long does the vaccination efficacy last? Dr. Johnson, there's someone on your team that can answer that, or maybe perhaps Teresa.
Okay, so how long does it, I'm trying to look for the question. So how long does the vaccine last? Like I said in the slide, if it is frozen, so if it's kept in the appropriate temperatures, it can last up to what's on the packaging of what's the expiration date, which is about 1 year from now, August 31st of 2023. Now, it really kind of can get tricky on how you receive the vaccine. So if you receive it frozen and you plan to thaw it out, it can stay out for up to 12 hours. After that, or really before that is preferable, it should go into the refrigerator. It stays good once thawed for 8 weeks.
Thank you, Javon. I think the intent of the question was how long is a person protected once they receive the vaccine?
Yeah, so I can take a stab at that one. So I think one question was about overall efficacy, and I think that's still to be determined, to be perfectly honest. The ACAM 2000 smallpox vaccine has been shown to be about 85% effective against smallpox. JYNNEOS is licensed to be used against both smallpox and monkeypox. But the effectiveness data, the efficacy data from JYNNEOS, I think, has been limited to information derived from animal studies. I know CDC is collecting data because I think they're trying to get a better idea about it. What we do know is that full protection is thought to occur 2 weeks after administration of the second dose. However, even within the first 2 weeks after the second dose, there's a pretty sharp rise in immune response to that dose, which is one of the reasons it can be used for post-exposure prophylaxis, because that immune response mounts quickly enough to be able to help prevent the disease if administered early enough, or reduce the severity of the symptoms. And I think there was another question about vaccine. Oh, how long it lasts. That's a very good question. That's one that I don't think we really know yet. But I think that the recommendation for boosters, I want to say it might be, and immunization may know this, that may be 2 or 3 years, if that's any indication of how long the immunity is thought to last.
Oh, and Sam, I don't have anything to add to that. I mean, I think everything Teresa shared is what we've seen as well. I hadn't seen anything definitive about how long the efficacy lasts with regard to JYNNEOS. And I guess there was a question about if folks had received the previous, I guess, smallpox or monkeypox vaccine, if that would protect them now.
So I think it depends on the amount of time, and this is something that unfortunately we don't know. But I think we're going to learn a lot, and it would I think a lot of folks who were vaccinated with smallpox when it was part of the routine immunization schedule were vaccinated, in the early 70s or before. So that's quite a long time ago. So I think it's questionable about what level of immunity might still be available from that dose. There was a more recent, I think 2003, effort as related to bioterrorism preparedness to vaccinate some healthcare providers. I think a limited number in Louisiana were actually vaccinated, but even still, that was about 20 years ago. So I do think that the recommendation, I think it's unknown the amount of protection that will be conferred from those previous doses. And I do know that there are recommendations for boosters, for example, people who are expected to be continually exposed, members of the military receive boosters at certain prescribed schedules. So I think we'll learn more as the outbreak evolves.
Thank you. And there was a question about how patients would find where they could go to get a vaccine. An answer provided. Thank you, Javon. Just want to make sure everybody hears that the best course right now is to contact your local parish health unit or regional OPH office. They can advise you. Certainly we'll have the vaccines available directly, but they can also let you know which community sites have them. And then I know Teresa mentioned earlier that we will be putting a list on the Monkeypox Dashboard of where community providers that have the vaccines are available. And we're working to finalize that now, and it should be up there early next week sometime at the latest.
And I do see that Dr. Holcomb asked if authorization for giving the vaccine would pass through the regional medical director within each regional office of public health. And for how it works for post-exposure prophylaxis related to a known exposure, the epidemiologists who are working with the case and identifying the contacts will provide the information to the regions just so they can schedule appointments with these individuals. When it comes to individuals seeking without a known exposure, but they meet one of those eligibility groups, they're members of one of those eligibility groups, and they want to get the vaccine under PEP++, those approvals do not have to go through the regional medical director. The provider sites that are administering the vaccines can make those determinations. And certainly we would not ask anyone to sign a document, do any sort of written self-attestation that they meet one of those criteria.
Thanks.
This is Elizabeth Britton. May I make a comment?
Absolutely. Go ahead, Elizabeth.
So I'm a nurse practitioner. I actually worked in the DRC in the Congo back in the late 70s, and we were probably doing the last smallpox vaccinations that were done because that is, of course, as she mentioned, that's where monkeypox also is coming from. And what they have shown with smallpox is it usually provides protection for decades. So we don't know, I don't know specifically about the monkeypox, but I did see a question in the box. Someone said they'd had smallpox vaccine before. Are they still protected? The answer to that is probably yes. So just wanted to add that.
Thank you, Elizabeth.
I think I hear somebody else maybe trying to ask a question. Still got a few minutes on the call, so please feel free to put a question in the chat or unmute yourself and speak. Okay, well, recordings, we've had a series of similar community and partner calls this week. The previous ones were really focused on those sites that we were hoping to partner with us on providing the PEP++ doses, but recordings of those and this will be available on the Monkeypox Dashboard. There's also a host of other resources on there, both designed for patient information, for general community awareness, as well as links and resources for providers, and lots of links to other sites for more information. So you can also, of course, reach out to us if you have follow-up questions or looking for anything in particular. We can help guide you to where to find it. But thank you again. Certainly, one thing that we can all do is share the information about what's occurring with monkeypox, distribute flyers if you print them out and hand them to patients, share content on your social media. Everyone's efforts in that way can be, can have a snowball effect and help us get the word out to people who really need to know what's going on. And stay tuned as this situation continues to evolve. We'll provide additional updates. Also want to just thank the Office of Public Health and the partners in the infectious disease EPI program, the immunizations program in our regional offices, the regional medical directors, disease intervention specialists, and regional administrators have all really been working hard and coming together on our state's response. And of course, we can't do that without you all, the community partners. So thank you to everyone involved for your help and assistance. And have a good weekend.
Thanks. Bye, everybody.